Good afternoon, everybody. I'd like to go ahead and get started so we can stay on time. We are lucky enough to have Dr. Rakesh Sindhi with us today from UPMC. At UPMC, he is the Director of Pediatric Transplant Research, Co-Director of Pediatric Transplant, Professor in the Department of Surgery and Transplant, and very, very experienced in the field of transplantation. We've already had a couple of very nice talks with him today, and he's going to talk to us today about immune monitoring and immunosuppression after transplantation. Please help me welcome Dr. Sindhi.
Well, thanks. Thank you so much for having me here. So by way of disclosures, much of what I'll discuss today is born out of technology that was developed in my laboratory. And we've licensed all of this to the University of Pittsburgh to a local company called Plexision, to which I serve as an unpaid consultant. So before I start, just a little introduction that even though I trained as a multi-organ transplant surgeon, I basically only worked with children for the last 17, 18 years at the Children's Hospital of Pittsburgh. And there, too, I worked with children who have received intestines or liver transplants. Very small populations by the standards of what you all do here in adults, but still a pretty challenging one and representative of the problems we see all the way across in solid organs. I've divided the talk into three areas, just to talk about the background and unmet needs, which I think all of us can agree on. And then the technological approach we've taken to understand both who is at risk for rejection and then who may do well with less immunosuppression. And these two characteristics are basically related to each other. And the last part is about working with people who have both rejection and opportunistic infections like CMV. And this is still a work in evolution, but it tells us that the relationship between infection and rejection is probably not as simple as we think. So this is a slide that anyone can conjure up in transplantation because what do we all face? We're always trying to get drug therapy just right. And in the process of trying to get it just right, either we're increasing drugs so we can get graft versus host, or we could get PTLD, and that's that slide to the lower left-hand side. Or we give too little and you can get rejection, and this is an intestine transplant patient in whom there is a stoma on the upper left-hand side. And you can see that the mucosa doesn't look that healthy. As opposed to someone who's got a pretty nice looking stoma. And so in children, it's very easy to sort of come up with reasons as to why these things can happen. Why? Because if you've dealt with children, you'll see little ones sometimes need as much medicine as some of the adolescents and the adults. And it's all because their metabolic rates are so different. The growing child has a high metabolic rate, so he just needs more drug because he just consumes it and spits it out. This other part is not as well recognized, but maybe some of you have encountered this problem or thought about the problem. If you simply think about a white blood cell count, you know that there are many of us who will live at the lower end of a range, say 4,000. And there are others of us who live at the high end of that range at about 10,000. And so if the guy who lives at about 4,000 goes up to 10, should we ignore it or should we really pay attention to it? And this becomes even more prominent as we deal with the immunological cells. For instance, if you look at T cell subsets, there is one cell subset that stands out in my mind because it's the natural killer cell. We've written about it a little bit from a totally clinical setting, and it turned out we noticed that people who had refractory PTLD, and PTLD affects almost 10% of our intestine patients, that many of those patients would actually have very low NK cell counts. And then we started to look at NK cell counts in a lot of patients, and we realized that the average Caucasian population person probably lives in the range of anywhere from 5 to 10 to maybe 15%. But many people who belong, say, in my ethnic group from the eastern part of the world probably sit around 15 to 20%, certainly in the 10 to 20 ballpark. And yet, we encountered a population of Middle Eastern patients, many of whom come with inherited type diseases. You'll have children with microvillus inclusion disease at the rate of 3 or 4 per family. And we noticed that their NK cell counts were pretty low. They all look like me, but their counts are low. And many of those intestine patients actually showed the highest incidence of PTLD after intestine transplant, where the incidence of rejection is such that we give them very high dose immunosuppression. And so really, what does this tell us? It tells us that we probably ought to have some way of standardizing the output of any test or any type of immune monitoring approach that we develop. And last but not the least, we're living in a strange world now. These numbers are great. We all know them. 121,000 people waiting for transplants. What we do, only 29,000 organs are short. What does it really mean in terms of why immune monitoring? I think today we have no choice but to ensure maximal graft longevity. We list patients frequently. Well, I won't say frequently because the incidence of the need for retransplants become a lot less after livers. But in the few that we have listed once every couple of years, we find we don't even get organs in a timely fashion. Used to be when I finished up fellowship in the 90s, early 90s, you could find a status 1 liver or a status 1B liver fairly quickly. Today they wait 7 days and then somebody in the family comes up and says, well, let me donate a segment and let's do the retransplant. So we really have to maximize the life of every graft. Somewhere in the year 2001, we initiated an R01 proposal where the idea was to try to look at lymphocyte activation status, much like the Silex principle. It was a good idea, and the thinking was if you stimulated cells with mitogen, very much like what you saw with the immunoassay, that perhaps the amount of interferon gamma, or let's say interleukin 2 or so on in different cells, here it's CD3 cells, here it's CD8 cells, and then here are some markers of activation in B cells. Perhaps the degree to which these markers were produced could be used to tell us whether the patient needed more drug or less drug. So what did we learn from that approach? Let's just look at this red bar. This really is the FK level, the average FK level that it takes to suppress the production of interferon gamma by T cells after stimulation with mitogen. So you're sitting at a nice number, about 10 to 12. And it's a half maximal suppression number. For those of us in pharmacy, it's easy to understand. It's an EC50, which is very similar to the ID50 or the IC50. The other thing we learned was that the rejectors, shown in red here, seem to need much more drug to accomplish the same level of inhibition. But the non-rejector needed less. Again, logical, because it stands to reason that for some reason the rejector always gets rejection despite therapeutic immunosuppression in the first few weeks after transplant. But then you started to look across the board at all these different markers, and you find that the numbers are all over the place. So the numbers are all over the place, depending on the cell and the cytokine and the marker you measure. What number actually translates into therapeutic effect versus a non-therapeutic effect or a subtherapeutic effect is really a very tough one to do. So how then could we take a simple cell and produce one marker from it and say, okay, we're predicting the degree of immunosuppression? The last thing we learned was that when you looked at patients shortly after lymphocyte depleting therapy, like thymoglobulin, which is very much used in, say, livers in intestines or in lungs, the high-risk organs, that the cells wouldn't even produce the amount of cytokine that they were producing here. And we had to go back to the drawing boards to look at a paper from Michigan way back in the late 90s by Jonathan Bromberg and by Bob Marion, which said that T cells treated with horse ATG actually were anergic to mitogen stimulation. And so straight away there, it takes away a lot of our patients out of the mix from that type of immune monitoring approach. So then what should we be doing? And in that study that we did over 4 years between 2001 to 5 or 6, we were doing this assay that we all know as the mixed lymphocyte co-culture. Well, in this assay, we look at both the response of the recipient to stimulation by donor cells, shown here in red, and the response of the recipient to a so-called third-party cell, meaning it's completely dissimilar from the donor and from the recipient and so on. And we noticed that the person who was rejecting in the first couple of weeks after transplant had a much higher response to donor than to so-called third-party. But when you looked at the person who completely went scot-free, no rejection, went home quickly, well, it was the exact opposite. He didn't seem to produce a big response to the donor, and yet the response to this garden variety human cell, which was HLA non-identical, was quite high. And it sort of was hard to ignore this thing, because if you express the two of these as a ratio, the response to donor divided by this, you'd always get a ratio over 1, more than 1. And this would be always less than 1. And I said, this sounds interesting. And it got rid of this idea that you had to have an absolute scale, like an ALT or an AST. It got into the fact that you could now compare patients on a standardized sort of a reporting format. And of course, it was a donor-specific response, not a non-specific response to a mitogen or some garden variety antigen. And it was these ideas that we took forward into the second project that we had, also funded by the NIH, where we said we had to convert this into something that would be clinically usable. For those of us who might be familiar with the mixed lymphocyte co-culture, the responses are measured as proliferation. And proliferation is measured as the incorporation of radioactive thymidine. And that takes about 5 days to really manifest itself. So even though the concept was interesting, and the MLC guys were pretty shocked. They said, we've been using it for 20 years, and how can this work? And I think we had to tell them that maybe you didn't look at the data carefully. The concept had to be boiled down into something usable for clinical decision making. And so this is where we spread our wings a little bit too wide here. The idea here was to get away from our lessons of taking too many markers and try to develop one marker or think of one guy that we could measure across many cells. Turns out when you just simply boil down the immune response, the antigen is sensed by the T cell. And this is that phase of antigen presentation. And from there on, rather than have a complicated idea, we said, well, two things are supposed to happen. One, the host divides and proliferates to conquer the invader, or it sort of itself lays down its arms and just kind of dies by apoptosis, and so it allows the graft to live. And this was a nice way to think about it, because we didn't get too lost in trying to do too many things. The next thing we did was we said, well, which marker and which system could be measured easily, and which one might be measured easily as a marker of activation of every cell type. Turns out this co-stimulatory pathway of 40 and 40 ligand was interesting, because that's how antigen-presenting cells talk to T cells. That's how T cells talk to other cells, B cells. And this is how B cells talk to other B cells to make them turn into antibody-producing cells. And the last property of this system was interesting. CD40 ligand is also known as CD154. It can be expressed without having to punch holes and do too many things to cells. And that's important because if you're thinking about automation as a long-term solution, making it reproducible, then it's best to pick up something that doesn't require manipulation to be measured. Many of the markers I showed you earlier, interferon gamma, etc., you need to punch holes in cells to measure it intracellularly. And that makes for a lot of inconsistency in results of a single assay between two people or between multiple runs on the same day. So the last thing we pursued was the idea that perhaps within all these T cell types, there was one that might be the best predictor of rejection. And how did we do that? What we did really was to look at CD40 ligand production by the recipient cell in response to donor stimulation and in response to the reference third-party cell, the non-identical cell. We divided these cells into 4 populations: memory and naive CD4 and CD8 cells. CD4 cells are loved by all. That's all we talked about until 10 years ago. CD8 was interesting because it was sort of the yin to the yang of CD4. And we said perhaps, who knows what might happen. And for every one of these cells, we measured the so-called index, that number that we mentioned to you. We called it the immunoreactivity index, donor divided by third-party response. And how does it show itself on a machine called a flow cytometer? Well, these are scatter plots on a flow cytometer. Here, every dot represents a cell. This is the base population, the parent population. This is the population that's making CD40 ligand or CD154. And you can see that in response to donor, there's a lot more as opposed to response to the reference cell. And so this was a person at high risk. Here's the exact opposite, where the inflammatory response to donor is exceeded greatly by the response to the garden variety reference cell, meaning non-identical cell. And we fed all these different indices for all these different cell types, for rejectors and non-rejectors, into logistic models and let the models do the job of picking out which was the best cell type. We did this exercise in 3 different organs, and it turned out every time the model picked CD8 memory cells which were making CD154 in response to stimulation. And so these are some of our earlier papers. These 2 liver and intestine populations are all children. The kidney population is an adult population. These were about 43 patients and probably our best study. It was a best study because samples were drawn on the day of a for-cause biopsy. And it's a good place to really try to develop something because the incidence of rejection on a for-cause biopsy probably runs about 46%, at least in the kidney population, based on at least 1 paper or 2 that I've read. In any case, the sensitivity and specificities are fairly nice, 80, 90%. The test itself had clinical relevance in that you could get the answer after an overnight cell culture. So if we got the blood, say, in the morning at 8, and we set up the assay, say, in the afternoon, then you could have an answer by, you could harvest the cells in the morning, and by about 12 noon to 1 to 2, you'd have the answer, and you were in good shape. Then we began to learn a whole bunch of other things. Here's a liver population exclusively, pediatric liver. We characterized this number, index, less than 1, more than 1, and really it was about 1.1. We characterized it before transplantation. We characterized it sometime during the first 60 days when our patients would experience the first episode of rejection, despite therapeutic immunosuppression. And then we characterized it once within the next few months all the way up until month 6. So these are all idealized time points. They're not exactly done on day 60 or whatever, but just to give you an idea. All these folks here in this plot are people who never rejected during this time period. And these are folks who had rejection, so these are considered rejectors. And most of their rejections were in the first 60 days. So the first thing you notice is that all the non-rejectors start low and sort of remain low, with a couple of exceptions. So they're like flatliners. But when you look at the rejectors of these various numbers of patients, I think probably like 10 or whatever, or 8 or 9, I think 8 of them out of 9 were actually at high risk even before the transplant. And that's an interesting observation, but one that we were not the only ones to make. This observation was made using the ELISpot by Peter Heger's group up in Cleveland when they first began to talk about the ELISpots. They found that 50% of their kidney transplant patients actually had a similar higher signal, a donor-specific type signal, even before transplantation, in those patients who went on to experience rejection and poor graft function in the first year. In our case, that number was probably in the order of 78%. So we had many things to think about at this point. It looked like there was something interesting going on, but the world of transplantation is a tough one in that, and the world of clinical medicine especially is also a tough one in that. If you walk around and say you've turned a mixed lymphocyte co-culture into a real assay, people are just going to laugh at you. And they'll laugh at you because laboratories that have been doing this for 20 years turned to us and said, how can you do this when we've been doing this? And so we asked them, I said, why do you do it then? Oh, well, we do it because the grants reviewers like to see it. Now, that's not a very good reason to do anything. So we went to the FDA, and I'd attended a lot of biomarker conferences, and there are fairly intricate, mathematically driven discussions. And the FDA said to us that, the path has to be, you all are working in an orphan population, very rare population. In an orphan population, you begin by getting an orphan designation for a product that seems to have some relevance. Then you come to us with existing data. As long as it's obtained correctly, meaning in a prospective fashion, under protocol, under consent, you can bring those data and we can look at it to see if it supports a claim. And that it seemed very easy at first. And I'll tell you some of the problems we went through because we went to them at about this phase. We went to them in early 2011, and by that time we had 147 samples tested, 120 subjects, and we gave them this wonderful document that we thought was great. But all of the work had been done with research reagents on research instruments. And so they looked at it and said, yeah, it looks interesting, but you got to narrow your claims. And most importantly, you have to reduce all of this into something that's reproducible and something that can be done on instruments and reagents that meet our standards, which meant we had to use GMP compliant reagents, and you can buy them. You had to use a flow cytometer that was FDA approved. We had to do a tremendous amount of reproducibility testing, which is what I told you were problems with some of the other assays. So we went back and we did all that, and we went back to them again. And so now they say, well, gee, welcome, do another cohort. And it's how hard it is to try to accrue all these patients in pediatrics. So anyway, we went back, we had kept collecting samples, so we used our archive, and we did this validation cohort, completely independent samples. And so here's an example of what the reproducibility testing looks like, and there are many, many tests that were done. In this test, what we did here was we did duplicate assays in the first run 1. We did duplicate assays in the second run. There are data for the number of cells that make CD154 in background and stimulated responses. And then we combined all of that, and we got a so-called coefficient of variation of about 6%, which is very acceptable. You have to basically give them an upper limit of what you consider acceptable variation. We said 20%. We were always below 10%. This was done on 20 samples. Then we had to do another 20 samples on 3 different instruments by 3 different groups of technicians and operators. Finally, we had to do pre- and post-cryopreservation assays to show stability. Why? Because all of our work had been done with archived cells. And that actually translates very nicely into practice, because very often, at the reference laboratory, tests will come in on a Saturday. We've asked people to ship on a Thursday, so we get to Friday, and if they come on a Saturday and there's no one to do anything, then you just freeze the cells and you can do it in the next week. You do between technician variation. We had to do day-to-day variation. And in every situation, our reproducibility was good because the mean coefficient of variations were less than 10%. These are just complicated demographics to show you the distribution of patients, samples, and all of this occurred over a 6-year collection period. The 7th year was about completing the testing. The entire FDA review took about 3 years, where we did all the extra work that they asked us to do. And our performance was always to be measured as sensitivity and specificity for our purposes, but they also like to see the negative and positive predictive values, which is really the number of true positive tests that were really positive and the number of negative tests that were truly negative. And these are those usual ROC curves which tell you that the sensitivity and specificity was good. So here are some numbers. Here's a training set. Our samples were divided into 2 groups. We tested the pre-transplant sample performance separately. Why? Because they had not been given any immunosuppression. So we expected those cells to be more active. All the post-transplant samples were pooled. Only one was taken from each patient. Whether they gave it early or whether they gave it late, we would only take 1 sample. The samples were divided into the training set, which was pre-2010, and the validation set, which was post-2010. And you can see the sensitivity and specificity, positive predictive value and negative predictive values are fairly similar. And mind you, these are completely independent cohorts. They've been tested 2 years apart. They've been tested with different versions of the same reagents. So this was quite nice for us to see. Next thing we looked at was pre-transplant samples. And even here, we had pretty reasonable sensitivities and specificities here, 80%, 71, 74, and 77. And in the validation cohort, the numbers were fairly similar, except in the sensitivity metric, where we saw the sensitivity drop to the 60% ballpark. And I think there's probably a bunch of reasons here. The first is that the sample size was very small here. It was only about 14 samples. The second reason is, and it's being pointed out by a lot of people, the ELISpot people, the gene expression people, they've all said that pre-transplant sensitivity is much lower than the sensitivity of a test during the time of rejection. And it stands to reason because perhaps the cells are not that primed, they're not as active, and it takes them a while. In fact, at least in one of the assays that will probably come out, this pre-transplant sensitivity is only 30%. So all in all, acceptable performance. And on the strength of these data, we received the approval, or the company that licensed our technology received the FDA approval to market the test for children less than 21 years of age for liver, who had received liver or intestine transplantation. There were a few questions we had not answered in this study. And one was whether the test was confounded by ongoing infection. Our problem was that between 2006 to 12, the PCR systems kept changing. One day we were doing some cell-based CMV stuff where it was about one cell per something or the other. The next day it was 100 copies or 10 copies, and the third day it was 1,000 copies. So because those thresholds changed so much, we did not take any commitments to try to understand or normalize them and make any sense out of those data, and the FDA accepted that. So we tried to address all of this in the next 180 patients who we monitored clinically at our center. And by the way, there are other centers using this test now. There's at least 7 or 8 pediatric centers using it. So these 180 patients were largely monitored late after transplantation because there's a big culture to do surveillance biopsies in pediatric liver patients. And the pediatric intestine patients anyway undergo a lot of surveillance biopsies. So we had to exclude 12 patients because they had all been pre-treated with some steroid before they came to the hospital, and then they got a biopsy to prove some lingering infiltrate of rejection. And those are patients where the test is always negative because it responds very quickly to a big bolus of steroids. Here are 3 scenarios that we learned about, which my partners use this test for. And mind you, these are not decisions I've made because I'm not allowed to. I have conflicts by virtue of the fact that the patents are all mine, and I can't order the test, and I can't tell anyone how to use it other than in this type of a format. So here's a patient with an intestine transplant who looks pretty good on day 15 on a surveillance biopsy. But something triggered the pathologist to look further, and they found a lot of adenovirus by adenoviral immunostain. And because there was no rejection, and drug levels were in this somewhat high range, the thought was that we should probably do the test. And if the test showed low risk, which it does here, it's 0.6, and the threshold is about 1.1, at or above which rejections predicted. At this threshold, we felt comfortable that the rejection risk was low, and the drug was lowered to far lower levels than we would tolerate at this time in the post-transplant course after an isolated intestine. So here are levels of 7, which we would never accept in the first 3 months even. And here's a pred dose of about 10, which you probably could get to, but still you'd probably be sitting around 15 BID or something. So clearly, the test helped us lower immunosuppression early. Here's another patient, very interesting. This is a child with jejunal atresia who had immune deficiency. She had received a bone marrow transplant, which told us that perhaps this person would not be as immune competent. We put a 1 haplotype match graft into her. This is an intestine again, and felt that she would do fine with lower drug levels and doses and so on. Well, when we did this test about the first 2 weeks or so, we found that the test actually predicted increased risk of rejection, even though the biopsy looked perfect. So you just look at it like any test. You have to put it all together with clinical course. And sure enough, a couple of days later, it looked like the mucosa had become a little more friable. We did a biopsy, and one of the hallmarks of rejection is actually apoptotic cells in the crypts of the small intestine. And we did see that. So in a way, it prepared us to go after rejection early. We actually did the biopsy a day earlier than we would have. We do twice a week biopsies on the intestines in the first month. So this helped us with early detection. Another problem we are starting to see with our surveillance biopsies in livers is that up to 20 to 30, even 40% of these biopsies show problems, even though the liver numbers are perfect. And it becomes difficult to do anything about these biopsies because they don't approach the threshold of rejection, not always like this. In this case, even despite normal numbers on a 5-year or whatever surveillance biopsy, this person had clear-cut rejection on a surveillance biopsy. And so here the test had already picked out high risk of rejection. And why is that important, you say? We're doing a biopsy, why bother about a test? Well, you have to think further down the road. If you increase the immunosuppression in this person, how do you know that this signal's gone away or this infiltrate's gone away? Unless you keep doing biopsies every few months. And I think if the signal's up here and the rejection goes away and this signal goes away too, perhaps you don't have to biopsy that frequently. And that becomes important in organ systems where surveillance biopsies are the norm because there's no blood test like a liver function test or a serum creatinine with which to monitor such patients. The lungs come to mind, the heart comes to mind, the intestines come to mind. So those are scenarios where this approach may help.
The cells that you're measuring to get your ratios, that's from a blood draw?
Yes.
Okay, and then that sample's handled how to get the cells that you're talking about?
So the cells are I mean, if it's the same hospital, for instance, Children's Hospital at Pittsburgh, they just get sent to our reference laboratory, which is the laboratory we've licensed to, and they set up the test the same day. If it's coming from outside, they get shipped to us overnight. They're shipped overnight at ambient temperature in a green top tube, just sodium heparin tubes, no special storage. And the cells are extracted by phycol prep. They are stimulated in cell culture. The next day, we perform flow cytometry after labeling the cells. We get the measurements and we deliver the index. So looking at these 168 patients, we also looked at the sensitivity and specificity of these tests that are now being performed in the clinical mode after the FDA approval. And what you see here is very much the same kinds of numbers, 80, 85%, positive predictive values in the same ballpark, negative predictive values in the same ballpark. And then we divide them by the liver and by the intestine. And here's a high risk, high immunological risk organ. And you start to see that you kind of do better here. But again, these are small numbers and so with the liver, maybe a little bit lower. Again, a lot of these patients are being monitored an average of 2,000 days post-transplant because we've done a lot more surveillance monitoring in our program now to get to these numbers as opposed to early monitoring. Most programs will perform 30 to 40 pediatric livers, or most big programs like ours will do so. And so the early patients are very few. What this did allow us to do in the last couple of years is to look at how the test performed in the setting of EBV viremia versus no viremia. And that's important in kids because these are immunologically naive patients. EBV is a big deal. PTLD is a big deal. And what we did here was to look at accuracy of prediction rather than sensitivity and specificity because you just don't have the numbers here to keep doing those smaller subgroups. So if rejection or non-rejection was predicted correctly, then we put that as a correct response or an accurate diagnosis. And you can see it's 82% versus 70% in the setting of viremia versus no viremia. There are a whole bunch of patients where either there is diarrhea or liver numbers go up after transplantation, and you do a biopsy, you find cholangitis or you find enteritis, not rejection. And again, 8 of 8 were picked up correctly in that they had no rejection. Here's this single child who we were able to capture during a high CMV viral load, and again, the test was picked up everything correctly. So the next question we asked ourselves was, why is this test false negative or false positive? We couldn't find anything that distinguished the false negative from the true negative test, so we have no reason, and I think that's a clean miss. The false positive tests versus the true positive test gave us some interesting insights. Most of the false positive tests occurred in patients who were sampled very late after transplant. And as you would expect, many of these patients were on much lower drug levels, as opposed to the guys who had true positive tests. So was this really a false positive, or was there something more to it? Was there more to these patients? And this is the breakdown of the liver transplant patients and the intestine transplant patients who had false positive tests. And what you see here are these 4 guys with livers, where the false positive doesn't really have a good explanation. In fact, you might even say it was confounded by the presence of BK viremia in a child who had both a liver and a kidney. But when you look at these folks, there's abnormal biopsies, there's class 2 DSA, there's failed weaning of drug on a national protocol, and these patients went on to have rejection. So it just tells us that we are probably still not at therapeutic immunosuppression, maybe. And you go down the list: mild portal infiltrates, chronic rejection, non-compliance, and previously abnormal biopsy. And the story gets repeated here with intestine transplants too, where 2 of the 9 patients are clinically stable, so we don't have a good explanation, but all the others have issues. Chronic rejection, previous recurrent ACR, and a lot of them are small bowel transplants only with no livers. This is a high-risk population. They lose their grafts at the rate of 50% every 5 years. So maybe a false positive test ought to just trigger the imagination a bit to say, we need to watch these guys closely. This is the work that I talked about that we did in kidneys, those 43 patients. And again, this version of the test is being used in some centers for adult kidney transplant recipients. So at the end of this work, which ended, I think, at the end of 2015, we at least able to say that we can measure rejection risk reproducibly across a few organs, that the measure is not confounded to the extent we thought it might be by infections, and enhanced risk in stable long-term patients, which is the false positives, probably needs some follow-up. The last bit is relatively short, and it's a little bit about the relationship between rejection and infection. And this came about because for those of us who've been around, there's a fair bit of issues surrounding how to assess CMV PCRs. We know all of this. Rejection can precipitate CMV. CMV treatment can precipitate rejection because you drop immunosuppression. Both the processes can occur together. We still don't understand what are the PCR thresholds to start and stop therapy. In children, all it takes is a positive PCR and we start. In adults, we've heard from our counterparts that we wait a little bit longer. We first lower immunosuppression before we start anything. And then what's more interesting is this problem. Many times during treatment, we see our PCRs go up, and there are these anecdotes that are bothersome, and some of them are my doing. You know, you come in to look at a patient, and you start treatment, and for some reason somebody sends a test on a Monday after starting treatment on Friday, and the PCR actually goes up. So now you go crazy, and you say, well, perhaps it's resistant CMV. And it makes you feel pretty good because you're thinking. And so you send a viral sensitivity test. And then the next day you're on the phone with the lab saying, where's the result of the sensitivity test? And the guy tells you it's a send out, it'll come back in a week. Well, you decide to do another CMV PCR on Thursday. And now it's even higher. So what do? You try to do the safe thing. You start Cidofovir. You stop the ganciclovir. Why? Because, what if? The answer is not back yet. Well, come next Monday, the PCR is down to 0, or probably 150, all the way from 4,000. Everything that you did in terms of reducing drugs seems to have worked, but the kidney numbers have gone up because you give Cidofovir. But, we clap our hands and say, we were so good. I did a great job. And on Tuesday, the test for sensitivity comes back and it's negative. So these are huge management issues that occur in this era of a lot of knowledge, where we try to do the safe thing, we try to anticipate, we're doing empiric stuff. But our ID people, infectious diseases people, always tell us we ought to be thinking about the host immunity. Now, host immunity has been interesting because these are ideas that come out of what's that test we use for tuberculosis monitoring these days? The T cell assay, quantiferon. So we're looking for T cells that make something in response to stimulation by a TB antigen. The same idea was put together into CMV-specific immune assays. And so what we did was to use our principle, which is stimulate T cells with this PP65 CMV antigen. Why? Because it's very easily available, and you can just buy it and you can stimulate your cells. And as an example, here's a person with a PCR that's positive. And these are cells that have been simulated, and these are only CD3 cells. And to equate all of this with the ELISpot, we're only measuring the response of 200,000 T cells. And so we see that there's not much response going on. This is all CD154 producing T cells after stimulation with the virus for a few hours. Now here's a person who's not infected, but also happens to be seroprotective. I mean, he's IgG positive, but PCR is negative. And when we stimulate his cells, you see a very robust response. But notice the cell counts, 40 here, and practically 4,000 here. When you start to put that in the context of some of the other approaches, ELISpots, etc., many of those counts run a few hundred cells, or probably tens of cells, 5, 10 cells here, 20 cells there, 100 cells there. So there's a good dynamic range that we were able to see here. Now we took these two categories of patients, and we did a few more, and we summarized all the data. These are the percent positive, percent of CMV cells. And you can see that in the infected patients who are PCR positive, there's a very low response suggesting there's loss of CMV-specific immunity. But in those patients who don't have active viremia, you can see a pretty robust response. And so we use this idea to try to figure out a couple of patients, and there's more data coming up now. And so how does this translate into, or how does it explain the sort of the strange relationship between rejection and CMV infection? So here's a patient who has elevated liver function tests and CMV viremia after liver transplantation. These are his cells with no stimulus. So they don't produce not a whole lot of CD154 cells. Here are the cells after stimulation with PP65 when the viremia is about PCR of 900. And you can see there's not much of a response. Now we measure his rejection risk profile, and he's at low risk of rejection. Now we don't know this, mind you. This is all being reconstructed retrospectively, and this was still done in the research mode. His FK level was 12, so we lowered his immunosuppression. We lowered the steroids. And a few days later, his level's down to 8, his CMV PCR 0. And when we look back retrospectively, it looked like they had reconstituted their CMV-specific immune cells. So this is a predictable type relationship which you would expect. Here's another patient in whom that whole principle sort of fails. He too has elevated liver function tests. And so you start off with this background type of cell production. During the phase of a PCR that's active, or CMV viremia, you can see that he's making just about 1% of cells. But interestingly, even though we did a biopsy that was negative, and we did a biopsy because the numbers were really a little bit higher than we wanted to see, his rejection risk profile suggests that he's at increased risk. So now we go ahead and lower the immunosuppression, not knowing what the risk profile is. We add antiviral therapy, and what happens? Exactly what I talked about. The CMV PCR goes up. We are scrambling around thinking of resistance, etc. And numbers are still high, nothing changes. And we do a biopsy and we find that there's rejection now. So the questions worth asking is, if we knew this then, before we started therapy, should we have just given this person antiviral therapy and not decrease their immunosuppression? And that's really the sort of the conundrum of treating infection and rejection. And this last slide is in the immune monitoring profile is about EBV. EBV is interesting because it's a virus that once it's there, it doesn't go away. And it presents a different problem in terms of how the immune system handles EBV. And probably the analogy that comes to mind is actually HIV, because once HIV comes in, it's not going to go away. So the question we had to ask here was, because the EBV PCR changes up and down and goes high and then it goes low, and there are these high load carriers and then there are these low load people, if we did spot measurements of EBV specific cells measured in much the same way as you saw CMV, the difference is here we stimulated cells with EBV virus lysate, just a virus crunched up into a little stimulant. What might we see, and what might the EBV specific T cells relate to, the highest load or the lowest load? So what we do here is, here I'm showing you the highest load ever accomplished by some of these patients, the intermediate load, meaning the second quartile, and then here's the third quartile, which is the high load people. And what you see here is that the CMV specific, or the EBV specific T cells are actually best correlated with the highest load ever accomplished by a person. There was no relationship we found between the lowest EBV viral load that a patient had after transplantation. And you can see that here, the first quartile, the second quartile, the third quartile, each dot is a point, and this is not a big population, about 16 patients. And so, but what was more interesting here was that the cell type that picked up this type of relationship was actually a naive cell type, and it was a T helper cell, suggesting to us that perhaps some resting immunity is just as important in handling many of these viruses that accomplish chronicity, or that just come in and don't go away, as opposed to some of the other viruses where the memory cells may come into play. Again, a very small population, but something worth thinking about. There's a couple of other slides just to illustrate to you what other people have told us about our test system. This is a picture that shows up when you read Dr. Starzl's paper and that he's written with others. And what he says is that the immune system sort of has a big response to the graft, and it just sort of dissipates over time. And as it does, so does the need for immunosuppression. And, we always looked at this slide and say, what's he talking about? And how does he know all this? There's no test to actually draw this, or for him to draw this conclusion on. Well, we had a colleague of ours has been doing hepatocyte transplants in metabolic disease, liver metabolic disease. And so here's a patient with phenylketonuria, and these folks have a pretty high PKU level. It's a toxic metabolite. And so he does the transplant here, and he also was using our test to see what the index would show, and anything above is high risk, anything below is low risk. And what he shows you is that the Phe levels, they stay kind of high early on, and then after the next several months, they're more in an acceptable range. And then one fine day, they go up for some reason, and they don't ever come down. And that's when the patient lost their graft and their cells, and they were non-functional. Well, what happens to the rejection risk here? You can see that it's up and down early on, and it sort of goes down very much like this picture that somebody drew ages ago with no test in their hands. And then way before the graft was lost, you can see this index spike up to tell you that the risk of rejection's gone up. We don't know why it went up. Was the patient not taking their drug? Were they fed up with immunosuppression? No idea. And this is the final slide, which sort of captures why we really set out to do all this. The idea was to really do safe drug minimization with these types of approaches, because for the most part, we can handle when somebody really has a flagrant rejection. You can see it in liver numbers, something, you can pick it up, although not for some of the other organs where there are no blood tests. But the longer-term problem is about keeping these people on not a maximally effective dose, but a minimally effective dose, which doesn't run the risk of too much toxicity. And so this is a prediction of the rate at which somebody would achieve a low FK level, and arbitrarily picked out as 5 nanograms per ml in the setting of high risk versus low risk. Very logical. If you're at high risk, you get rejection, so you're going to treat them longer with higher doses of drug. But hopefully this is a message for us to say that perhaps the greatest use of these approaches is to combine them with all the available information to really manage drug in a longitudinal fashion. So in addition to the three things I mentioned above, I think we have captured why anti-donor and antiviral responses have a complex relationship and it's not easy to understand. But at the end of the day, all of these diagnostics are adjunctive, and we ought to really use them with all the available information. So a lot of people to thank. These are my partners, other colleagues from other services, and all the grant funding that we've received. Thank you.
Excellent talk. Thank you very much. With the way your assay is set up, has anybody at your own institution used it in type 1 diabetics or pancreas?
We'd love to see people use it. Nobody has used it yet.
Because what I'm getting at there is that where you have the component of autoimmune reaction, which may in some cases be greater than an allo reaction, one, would you be able to detect that? And then also, would you be able to differentiate it all between an allo and auto?
Actually, we have an example in our own program. It's a patient that we reconstructed retrospectively, but it's a patient that's actually discussed in an editorial I wrote in Pediatric Transplantation on alloimmunity, autoimmunity in liver transplantation. As you probably know, there's this idea that many of the pediatric liver patients will start to have high liver numbers due to spontaneously developing autoimmunity when they never had it before. We've had a patient like that who showed up off and on. I think he had cryptogenic cirrhosis, or not something that we would immediately associate with autoimmunity. Got a transplant, and starting about probably several years, probably 10, 12 years after transplantation, began to have high numbers. And what we found was that he had that classical interface hepatitis with plasma cells, suggestive of autoimmunity. And interestingly, in those episodes where the numbers were associated with that type of infiltrate, our test was negative. And whenever he would have a true portal infiltrate suggestive of rejection, he actually would have a high risk for rejection. So I think as little data as we have, the donor specificity of this response is probably something worth testing out in those types of patients.
Then along the same lines where you demonstrated the use of the test in the setting of CMV, have you looked at it in liver transplant for hepatitis C, type of similar relationship?
I think we're still waiting for people to try it out. Some of the adult transplant surgeons did say that they wanted to try it out. We're waiting for them to try it out. I have a feeling that they'll be pleasantly surprised. I think we're just waiting for people to do it.
But you've tested it at Pittsburgh. I mean, you have in the adult population.
We have an adult population, but for all practical purposes, we are very distinct programs. I mean, we live about 4 miles apart, and much of what we develop first gets tested out in our systems. So,
Not a lot of data yet that you can share with us.
what's that?
Not a lot of data yet.
No, we don't have any data on adults, not from livers anywhere. We have some adult kidney data that's evolving in other centers. We have some pediatric heart data that's starting to show up in other centers. A pediatric lung program is testing out on a limited number of patients how to use this test. And their goal obviously is to reduce the incidence of surveillance biopsies over time or to pick up rejection early. So we're seeing some very interesting things out there.
Right on time.
Sure.
I understand the example that you gave of a child that was auto, did a biopsy,
Yes.
used a cellular infiltrate, with more typical autoimmune reaction.
Mhm.
Did your assay, and the assay was negative.
It was negative.
Then later on, they had like LFT abnormality,
Mhm.
another biopsy.
Mhm.
Cellular infiltrate that looked more like rejection,
Mhm.
and then your assay replies.
That happened quite a few times actually.
Patient or
Same patient. He would bounce in and out of different looking infiltrates. So we've described his clinical picture in an editorial that we wrote in response to somebody who talked about autoimmunity and the relationship to alloimmunity. We hadn't looked at the test results then. But the interesting thing about de novo autoimmunity in liver patients who have not had autoimmune problems before is that you can get over that autoimmune problem with much lower amounts of steroids than a classical rejection. In a classical rejection, you're always doing the recycle, high dose steroids in 3 days or 5 days, whatever you pick. But in the autoimmune setting, just about 20 of steroids once a day or so was just good enough. It was just over. 3 or 4 days is about all we did, and the numbers would normalize. So very interesting. I mean, it was new for us too.
Thank you very much.
Thank you.
I
Oh,
think we had a question about.
I see Dr. Adriana's name there, and I was curious to know if in those cases with the high risk of rejection, was there anything correlated with the HLA testing?
yeah, I was waiting for that question. So I think we have some data on some of these patients in the clinical mode, because DSA is more and more. Adriana has really pushed it all over the place to get it in to be used a lot. And yes, many of the patients who have a positive, a high risk with our cell-based test will also have positive DSAs. But it's an interesting mix. Some people only have the cell-based marker that's up. Other people have just the DSA that's up. And then there are some that have both of them that are up. And most of these types of observations are coming up in the surveillance mode, say at 5 years, 10 years after transplantation. The difficulty with correlating what we have with this cell-based test versus the DSA is that if you look at the response to drug, let's say somebody gets a steroid bolus, you're probably going to have the DSA be about the same level. It's not going to change. But if you take a T cell or any cell-based response, it basically falls flat. We have a whole bunch of other tests that look at cellular activation. So the interesting thing about these types of tests is that they respond acutely, and they're probably really well suited to monitoring changes in drug therapy. Many of our DSA patients are now false positives. In fact, the incidence of false positive is so high that if a person has a perfect biopsy but a false positive test, it probably has less meaning in the DSA setting, say moderate to high risk, or moderate to high, whatever that MFI is. The other problem we're seeing is that there are so many specificities of the HLA, whatever. And the last piece is, what do you do with it? I mean, at the end of the day, a test has to give you actionable intelligence. I'd love to see data that says, okay, we increased the immunosuppression, and everything went down and disappeared. It doesn't. It may go from high titer to moderate titer, but what does it mean? The last piece is, okay, you've got moderate and then you've got high, and then we say we do C1q binding. What does C1q binding mean? Because at the end of the day, C1q and other complement factions bind to one isotype more so than the other, right? And yet here we are measuring unfractionated IgGs. And then you have Dixon-Kaufman saying, if you dilute out the high titer antibody that is C1q binding, it loses its C1q binding. And if you talk to Margaret O'Leary at Columbia, she says she can reconcentrate the high titer antibody, which was diluted, and restore C1q binding. So are we better off just measuring antibody titer, or do we have to keep doing C1q and something else and something else? So I think there are some limitations to every approach. But yes, there is some correlation, but there are others where there's no correlation.